أجمعين يا ربي آمين.
Ameen. Okay, our first case, inshallah. This is a child. Okay. Who want to start, inshallah? This is our first case. Anyone to start? Anyone? Anyone?
مرحبا أستاذ.
أهلا بك. Anyone want to start? Okay.
PA chest X-ray of the child
Okay.
showing abnormal opacity involving of the right middle zone of the right lung.
Right middle zone of the right lung. Okay.
In normal right side heart border, not يعني not saluting the right heart border. That's with the mild pleural effusion of the left involving of the left costophrenic angle.
This patient, it is little bit rotated. You see here in the right side, as you said, this is
Yes.
a prominent pulmonary vessels, okay? Pulmonary vessels. There is any other things
No.
other than this?
يعني this
Other,
is
other
يعني
than
of the upper mid
there is another things very important.
widening
Check
of the upper mediastinum, anterior mediastinum, widening of the anterior mediastinum.
No, this is normal child, okay? Other things. Where's the left diaphragm? You see the left diaphragm?
Yes.
Okay, you see the heart?
Yes, I see the heart.
Okay, anything behind the heart and crossing the left diaphragm, going to the upper abdomen, you see that?
Yes, there is soft tissue swelling.
There is soft tissue swelling here, and you see here, okay? It is retrocardiac, okay? And it is seen in the lower chest and upper abdomen. And okay, what is this? Anyone who can describe? Okay, Muhammad Musa, you can, okay. محمد موسى رافع ايده اذا بدك تجاوب. محمد موسى. Anyone? So this is a mass lesion in the where it is located, that mass lesion. I will help you.
Retrocardiac.
It is retrocardiac, extend to the, you see the mass through the diaphragm, okay?
Doctor, maybe aortic aneurysm?
This is child. This is child.
Scimitar.
This is child. Wait, don't jump. شو اسمه? Don't jump. Okay, I will help you. Okay. This mass, it is oval in shape. مظبوط ولا لا? As seen in the BA chest, okay? Or in the chest X-ray. That mass, it is seen through the diaphragm. And we see that mass. And once we see the mass in the above and below the diaphragm and not obliterating the diaphragm means that what? Anyone? Means that it is
related to IPC.
This mass
means paravertebral.
Yeah, it is paravertebral mass, and we see the mass above and below diaphragm. Okay, And this sign, anyone remember this sign? Thoraco-abdominal sign. Thoraco-abdominal sign. We see the mass in the thorax and the abdomen and through the diaphragm, and this is thoraco-abdominal sign. That thoraco-abdominal sign, okay, means that the mass, it is located where? Anterior mediastinum, posterior mediastinum,
posterior.
posterior mediastinum. So this is the mass located in the posterior mediastinum. Okay, very good. And what are the differential diagnosis of posterior mediastinal mass?
Teratoma.
Teratoma, this is mainly
Neurogenic.
anterior, mainly anterior teratoma.
دكتور قسمهم نيوبلازم and non يعني نيوبلازميك تيومر إذا
Neurogenic tumor, like what?
مثلا
Neuroblastoma.
Neuroblastoma, very good. Neuroblastoma,
paraganglioma.
paraganglioma. Okay. Okay. Other.
Schwannoma, neurofibroma.
Okay, these are the differential of the diagnosis of the posterior mediastinal mass. So this is the posterior mediastinal mass.
Lymph node.
Lymph node. Okay, but it is rare lymph node. It in the posterior. Yeah.
Interexist. Posterior.
Interior neurointerexist. Okay, very good. This.
Doctor, aortic aneurysm.
Aortic aneurysm, but this is child. You see, this is child. Yeah. Okay.
Schwannoma.
Extramedullary hematopoiesis.
حكوها. Okay. This
Extramedullary hematopoiesis.
extramedullary, usually bilateral. Okay. Usually bilateral.
يلا
Okay.
اكلمك بعدين.
Okay.
دكتور شوانوما ممكن ايضا.
حكوا schwannoma. Okay. So why it is posterior mediastinal mass? It is obliterated in the the left paravertebral line, and we call this sign thoraco-abdominal sign. This is important. It is important.
Diaphragm obliterated.
Yeah. Diaphragm, it is not obliterated, by the way. You see the mass above and below diaphragm, and you see this is, it is not obliterated here. Okay. It is, you see the mass through the mass. Okay. So the mass, it is located posteriorly, okay? And this is the lateral view of the child, and this is the mass, it is posteriorly located, okay? What is next step?
CT scan.
CT scan.
CT scan, okay? This is the CT scan of this patient, okay? Anyone who want to see what is that?
Neuroblastoma.
Maybe
Also, we want to
Left
describe.
paravertebral.
We want description. Try to standard your answer step by step. What is this? What is the procedure? What is the finding? You describe the finding. حكينا differential diagnosis. And most probably we need the diagnosis. مظبوط ولا لا؟ Okay.
مضبوط.
Okay. This is CT. This is selected images of CT scan at the level of lower chest and upper abdomen. Okay. This is
L1.
okay. Showing
دكتور تحب أحكي؟
تفضلي.
This is, as you said, this is CT scan with the IV contrast showing well-defined mass noted at the lower thorax, maybe at the level of T7 or as I see, T8, with the small calcification inside. And the lesion is relatively well-defined, and it is in the medial aspect, left side. And there is no evidence of intravertebral foramen invasion or intraspinal extension, as I see in the selected images.
Very good.
And it is soft tissue, and There is no evidence of bony invasion or
Okay, very
involvement.
good. Very good.
And
Okay.
in the, as we see, we said it is in the prevertebral para-aortic region. And this is the most likely differential diagnosis, as we said before, neuroblastoma, schwannoma, neurofibroma. But
Okay,
with
this is a
such appearance,
neuroblastoma, or
yes,
most likely to be a neuroblastoma. Be more specific and confident. Okay.
yes, because of evidence of his child and calcification and paravertebral,
calcification,
most
okay.
likely it is a neuroblastoma.
Okay, very good. Okay, neuroblastoma can arise from the sympathetic chain in the neck. Okay, can
Yes, in the neck, but below it is parasympathetic.
below it is parasympathetic. In the thoracic also can arise, and in the pelvic and in the adrenal gland. Okay, ماشي. Okay, as
Yes.
we see here, this is solid mass with punctate calcification, and it is oval in shape, obliterating the left paravertebral line. Okay, and here we don't see any extension in this cuts, at least extension to the neural foramen.
Intraspinal.
Okay. Okay, and with this patient, with the neuroblastoma, the calcification, it is common. Anybody remember the percentage of calcification?
30%. 30%.
No, more than 30%. More than
80.
80%. It is above 70%, 70 to 80%. Okay. اوكي then above 70 to 80%. طبعا حكينا احنا differential diagnosis in neuroblastoma, ganglion, neuroblastoma. What is the difference between neuroblastoma or ganglion neuroblastoma? Any difference?
الage.
In older.
الage, yeah, difference. I think I did not remember exactly, but the main difference it is in the malignancy potential. Okay, malignancy potential. With I think in the ganglion neuroblastoma, it is more malignant potential than the neuroblastoma itself. Okay. As I remember, but check the شو بسموها, check the information in the box please, huh? Okay, طب what are the markers we want to search for, the markers in this patient? Any markers we want to look
ممكن
for?
ال MIBG نعمل ولا
نعمل
قصدك دكتور؟
MIBG, yes.
It is negative.
Is this it is negative or positive?
يكونون المفروض سوري لأنه secrete catecholamines فتكون positive.
Positive. And it is diagnostic also. Okay?
Yes, it is diagnostic MIBG.
Okay.
Yes.
Any other clinical markers in the urine?
Female mandelic acid.
Okay. Female mandelic acid, VMA, and it is we see it in the urine. Okay, very good. Okay, this is a neuroblastoma, this patient, and some information about the neuroblastoma. It is a tumor of a neuroblastic origin, okay, along the sympathetic chain. In the neck about 5%, thoracic 15, abdomen 16, and in the pelvic 5%, and in the zogal gandil and the presacral about 10%, as I remember. Okay, clinically the patient, it is elevated catecholamines, as you said, VMA, it is elevated, and patient, it is between less than 80% of patient less than 4 years. Okay, and imaging, as you said, it is solid mass, beyond the adrenal, and it is displacing the kidney, crossing the midline, increasing the abdominal vasculature, can extend to the neural foramen. 80% calcification, as we said, the differential diagnosis and complication, it is metastasis to the bone, and about 50% it is a diagnosis, spinal canal invasion, lymph node, lung, and liver metastasis. Okay.
دكتور النيوروبلاستوما with الكيموثيرابي تكون كثير يعني تستجيب صح؟ especially إذا كان في intraspinal invasion.
إذا بتستجيب كويس، وبعدين حتى في منهم أظني as I remember stage 4 stage 4B اللي بتكون بالليفر ومع سكال نديوز، ومع هذا كان بي also شو اسمه كان بي spontaneous regression some of the types.
لأنه كان عندنا يعني بالهذا يعني تقريبا خلال 3 أيام مراقبة مع الكيموثيرابي يصير vanishing للتيومر تقريبا خاصة إذا كان intraspinal invasion والأطفال الصغار.
Any question about the neuroblastoma? طبعا بدكم تقرأوا أكثر عليها. طبعا نحن مش شرط إن نعطي كل المعلومات الكلينيكال، at least إحنا we give the tips, radiology tips on that. Okay. كل واحد الله يخليكم يسكر الفيديو تاعه، ما حدا يفتح الفيديو تاعه. Okay, next, our next case. Okay. This is our next case. Anyone? Patient with back pain? Anyone?
That I said tethered spinal cord.
حكينا رجاء حكينا step by step. We want to learn step by step، لأن إذا تعودتوا على step by step you will not forget in the examination. Okay.
Excuse me, can I explain?
Okay.
دكتور إذا أمكن تعيد الهيستوري.
Back pain.
Excuse me, can I explain the image?
Okay.
Spinal MRI, sagittal MRI, T1 and T2 image, showing that the conus medullaris is blue, lumbar 2. I think it's tensor cord.
Okay. At what level it is insertion in this patient?
In this patient, it's blue sacrum. It's now, I think, maybe lumbar 5 or sacrum 1.
S1, okay.
S1.
Okay.
Yeah.
Few other things? Other findings?
Yes. I think there is it's maybe the changes at vertebral end plate.
Where?
Excuse me.
T11 to 12.
Yeah.
T11, T12.
Is the low signal in T1, high signal in T2, so medic change type 1.
Modic
T12,
changes
T11,
type,
yes.
Are you sure it is modic changes?
I think
can be
type
infection.
2.
It's low in T1, high in T2.
High in T2, okay.
So it is edema.
So it is
edema, yes. So type 1, I'm sure it's type 1.
Okay,
No.
type, okay. Other differential could be not modic changes.
Could be discitis.
Discitis, yes, discitis. Edema, yes.
Why discitis? Why discitis?
Discitis is a discitis due to infection. I think discitis, most of the marrow edema, the only marrow edema that have, but it's not signal intensities. I think maybe discitis also.
Why?
Maybe but irregular.
Increases signal intensity.
Increase signal.
Okay, we have
high signal intensity in the adjacent end plate.
Signal density in the disc. Okay, well, this is one. Second, and also irregularity of the end plates. Okay?
Yes, yes, yes.
This is the second finding. You see here there is some increase in signal intensity in the of this patient at that anteriorly, and also some irregularity, but the patient has no signs of infection. What could be?
TB, early TB.
ما عنده change of signs of infection at all. What could be?
Post-operative?
No, there's no any operative changes in this patient here.
Hemangioma?
Huh?
Hemangioma?
No, this is not.
No, not hemangioma.
No, not hemangioma.
Secondary metastasis?
Degenerative changes.
Degenerative, yeah, this is young child. This is young child. Could be smaller node. Could be smaller node.
Smaller nodule?
Smaller nodule or smaller node. Okay.
Sherman disease يعني?
Could be another diagnosis, Sherman disease. Okay. One of the differential diagnosis. Okay. So not everything increase signal intensity in the disc. Okay. Not increase signal intensity in the disc. It is infection. Okay.
دكتور
how we prove that?
اكو kyphotic change بالvertebrae?
Okay, there is kyphotic changes. How we prove that it is not infection?
Contrast.
Infections, I think infection must be, we have the contrast administrations. If there's no contrast administrations,
no.
Enhancement?
No, enhancement can be both, even in infection or non-infection, even in mechanical. Okay, this is one of the causes, mechanical causes.
هي إذا كانت infection هاي بهيج حالة، وإذا ماكو يعني sign of infection على الجليد فممكن hematological يعني osteoma لا hematological. أنا أشوف إذا أكو secondary site mal infection أشوفه يعني غير مكان مثلا.
If there is any signs of infection, we should do what? MRI. This is MRI. في any sequences MRI بتعطيك إنه there is infection.
Diffusion weighted.
Image. Yes, diffusion weighted image.
Diffusion weighted image. Okay, very good. And restriction in the ADC will give you some sort of infection. إذا منا another investigation. إذا منا another investigation, what? We can do bone scan also. 3 phases bone scan. Okay. Okay. Okay, this is a patient with tether cord, as you said. Okay, it is ending in the, it is ending at the level of S1, and also there is changes at the T11, T12, probably not because the patient has no signs of infection, could be smaller node or Sherman disease. Okay.
Doctor, I have a question, please.
تفضلي.
Doctor, please, can you describe for me, in this case, disc is normal? Disc is abnormal?
Disc, it is, this is the disc space, it is as the height is normal, but the signal inside the disc, especially in the nucleus bulbosus, it is little bit high, but it is not increase as water density to suggest infection. Okay. And the second thing, the edema around the vertebra, around the end plates of the vertebra, it is well defined, and probably this is what we call it a smaller node, acute smaller node in this patient, or aggressive smaller node findings. Okay.
Okay, Doctor, what about this? Is you say this is a child?
يعني young child, about 17, 16, yeah. About 16, 17, yeah.
Adolescent.
Yeah.
Adolescent. Doctor, how you know the main key for this from the far? You know this is this age?
We know the age of the patient before, actually.
If it is no,
from the image, we don't know from the image. But there is a clue here, a clue. What is the clue here?
The bone marrow.
أول شيء bone marrow. Second, anterior superior corner, we call it limbus vertebra. You remember that? It is not ossified.
Yes,
okay, it is not ossified. So this is not يعني most of them here at that level. This is 5 4 3 3 و2. اوكي 3 و2 وحتى هنا 1 وكمان هنا كمان 1 هنا T11 T12 كمان it is not ossified. So this is a child. لو كانت وحدة لحالها, this is limbus vertebra, this is a normal variant, yes, but here multiple limbus vertebra, so this is probably it is young adolescents, okay? Any questions?
Okay, thank you.
Thank you.
عفوا دكتور, الانفكشن هو اللي بيكون restricted بالديفيوجن.
الانفكشن بيكون restricted بالهذا, وبيكون كمان عندك اذا في abscess formation, it is more with abscess rather than with infection.
طيب بدون الابسس الله يسلمك, اللي بتكون restricted الإديمة والديسك سبيس, يعني بيكون برايت بالديفيوجن ولو انتنس بالاي دي سي.
بتكون شوف هنا الديسك سبيس it is relatively slightly high in signal intensity but not reaching the water signal intensity. This is against infection, by the way. Okay, this is against infection. Okay,
تسلمي.
The third cause, it is failure of closure of posterior neural tube and imaging thick filum terminally, low conus medullaris, normally at the level above the level of L2, L3, and can, as we see here in this our patient, at the level of S1, can be associated with fatty infiltration of the filum terminally, okay? And the patient clinically occult skin coverage with the spinal dystrophism, and mild spinal dystrophism can be seen, okay?
Okay.
Okay, this is next test.
This is scrotal.
Scrotal ultrasound. Ultrasound scrotal ultrasound.
اوكي منا وصف لو سمحتوا, منا وصف, منا شوف step by step. We want the procedure. Second, finding, observation, finding. Third, we want the differential diagnosis. Fourth, want most likely the diagnosis. Fifth, we want our recommendation to the treating physician. Okay, try to answer, try to fill these 5 points, okay, please.
It is longitudinal scan of the testicle.
Okay.
A scan, ultrasound of the testicle, showing prominent rete ectasia, which is normal finding.
اوصفها هاي.
لازم نوصفها.
It is a cerviginous appearance of the mediastinum of the testicle, showing dilated arteriole, cerviginous in appearance.
Dilated arteriole? Huh?
No. دكتور إذا راح يروح الوسط.
ما تلخبط. ما تلخبط. It is not dilated arteriole.
الوسط against the face.
Seminal, the drainage part of the seminal vesicles, from the testicles to the vas deferens.
Wait, okay. It is first. حدا واحد بدي يساعده؟ مين بدي يساعده؟
دكتور أحكي؟
احكي تفضل.
This is a sonographic picture of the testis. Showed multiple small cystic tubular anechoic structures replaced the testicular mediastinum, and it is geographic in shape with
so this
no
is
mass
tubular structure in the mediastinum of the testis associated with the small cyst here.
Small cyst and the tubular anechoic structures.
And anechoic structure. Okay, very good.
There is no mass effect.
No mass effect. Okay, very good.
And we must see also the vascularity as in the Doppler also lack of internal vascularity.
Okay, very good. إذا a vascular and okay. What you see is أنا أعطيتك كمان صورتين.
This is cystic structure.
Epididymal cyst.
Epididymal cyst, multiloculated epididymal cyst.
Epididymal cyst.
Yes.
Multiloculated epididymal cyst can be associated with retitestis or retiectasia. Okay.
Tubular
What
ectasia.
is this tubular structure? What represent?
Which one, Doctor? In the testis?
Yeah.
In the testis, it is the tubular ectasia of the retitestis.
Okay. What is the? It is coalescence. Alaykum assalam. These are coalescence of seminiferous tubules. Okay. These are seminiferous tubules at the level of the mediastinum of the testis. Can be bilateral. Can be also symmetrical or asymmetrical. As you said, it is avascular and it is not palpable by treating physician. Okay. And this also may be due to obstruction of the epididymis or efferent tubules who vas deferens, and it is increased post-vasectomy. And as we said, it is associated with epididymal cyst, as we said here in our patient, multiloculated epididymal cyst. And okay, this is a normal variant, by the way. Okay, this is a normal variant. Okay, any question on retitestis?
Victor, it is a lack of vascularity. So vascular, we can put the differential diagnosis.
We can put the differential, but lack of vascularity. But he started, these are dilated, cerviginous dilated arterioles. It is not arterioles, okay? He started like this, I think, huh?
أكيد, Doctor.
Okay. This is our Ain Shams, okay? Okay, this case. Anyone? This case, simple case?
دكتور this chest X-ray.
شوف chest X-ray بدي الخمس نقاط تجاوب عليها، ماشي؟ اوكي؟
اوكي دكتور.
توكل يلا توكل.
BA view دكتور.
Frontal chest X-ray.
Okay.
Showing left side of the left hemithorax.
طيب right وين؟
Right upper loop. Right upper loop.
الفايف يعني starting with lung pathology first and then we comment on mediastinum and then bone change and then costophrenic and cardiophrenic angle. This is the items.
يعني ما وينه هذا اللي
دكتور نت ضعيف شوي نت راح.
طيب اوكي النت عندك ضعيف. يا مين بده يحكي؟ مين بده يحكي؟ مين اللي حكى قبل شوي ويستارت قدام ميديستاينم بوني كيج لونجز اتسترا؟ مين؟
دكتور أحكي؟
تفضلي.
Chest X-ray PA view of mature skeleton showing right upper zone homogeneous opacity with S-shape border, clear both cardiophrenic and costophrenic angles, no soft tissue mass or bone lesion. I suggest upper loop right mid upper loop collapse.
اوكي
لا غلط.
لا واحد قال لي غلط، شو رايك؟
This is mediastinal mass.
Mediastinal mass.
Okay, this is a mediastinal mass. Why it is a mediastinal mass?
Because of silhouetting sign.
It is silhouetting the
broad base to the mediastinal and the
broad base opposite to gland border.
And
extending
the
above
right,
the clavicle.
Right
this is
cardiomediastinal silhouette on the right side. Okay? This is one.
Okay.
This is one. So it is located where?
Anterior mediastinum.
Anterior mediastinum.
Another sign here. Another sign.
عفوا لو واحد يتكلم بس أفضل.
تفضل. Another sign in this patient. What is the another sign? The mass reaching the clavicle or not?
Above the clavicle.
Above the clavicle. Are you sure? It is across the clavicle.
No. It's below the clavicle.
It is below the clavicle.
Below the clavicle, not reaching.
So the mass is below the clavicle. So this is another sign of anterior mediastinal mass. Okay.
Cervicothoracic sign.
And another sign here, you see blood vessels through the mass. مظبوط ولا لا in that area? What we call this sign?
Overlay sign.
Overlay sign. Very good. Overlay sign. Okay, this is so the mass. It is either located anteriorly to the blood vessels or posteriorly to the blood vessels. But we said this is the mass silhouetting here. So this is it is anterior. Okay. Another sign. You see here the mass. It is well defined. But we don't see the upper portion of the mass when it is reaching the clavicle. So this is another sign. This mass, it is not intrapulmonary. It is what we call this sign? Incomplete border sign. Incomplete border sign. So the mass here. This is, so the mass here. The mass here, so it is located in the anterior mediastinum. And here it is located in the anterior mediastinum. وجاء سكروا. Okay. Bilateral, where is located the mass?
Anteriorly.
It is located anterior. Which space?
Superior.
No, it is not. It is in the retrosternal. It is retrosternal space. Retrosternal space. The retrosternal space should be loosened like the spinal space. Okay? So the retrosternal space should be loosened. Any obesity in any of them, there is pathology of any of them. إذا كانت high opaque, إذا pathology in the spine, and we call this spine sign. إذا كانت high opaque, we call it retrosternal sign. Okay? So this is anterior mediastinal mass. What are the differential diagnoses of anterior mediastinal mass? What are the differential diagnoses?
Retrosternal goiter, thymoma.
40 or 5 T's?
Thymus gland
Okay.
tumor.
Five T's.
Tumor intestinal goiter.
Tracheal pathology. Tracheal pathology.
Teratoma.
Tracheal pathology.
And
Tracheal pathology.
Lymph node.
Tracheal, no. And lymph node. Okay, lymphoma. Okay. And we put another T. We call it 5 T's. And that 5 T's, where is that?
Teratoma بقى ولا ايه؟
5 T's. حكينا ثايرويد، حكينا الليمفوما، تيراتوما and ثايموما، حكيناهم هذول الأربعة. and we should another tons of another 5 T's اللي هو another causes like vascular causes, foregut cyst, lymphangioma, hemangioma, aneurysm, etc. etc. Okay, these are differential diagnosis. Actually, it is 5 T's, not 4 T's. Okay, thymoma, teratomas, lymphoma, thyroid, and tons of other. Okay. Remember that. Okay, so we have mass lesion in the anterior mediastinum in the chest X-ray. What is the next step?
CT scan. CT scan with contrast.
Okay, CT scan with contrast.
Contrast.
This is the CT scan with contrast of this patient. What you see?
homogeneous
retrosternal
space.
We see mass lesion in the anterior mediastinum enhancing.
This is CT scan.
Lobulated,
Yes.
and it is across the midline. What question you should ask now?
Age of the patient.
Okay, very good. We should ask for age of the patient. Okay, this patient has about 50 years old.
So it goes with the thyroid, retrosternal goiter.
What's the age, sir? What's the age?
50 years.
50 years. So I put lymphoma.
You put lymphoma. She
I-
put
as differential-
thyroid. She put thyroid. anyone put another
thymoma.
Thymoma the first.
Okay. We
Thymoma
should
and
put
lymphoma.
thymoma
Doctor,
number
before
one.
the differential diagnosis.
We put the differential diagnosis. The next
لا
step
دكتور
we put the differential diagnosis. The next step and want to see the age of the patient. If it is young, it is more with lymphoma. If it is above 40, 50, 60, it is likely thymoma. Okay?
but we دكتور مو المفروض همنا نحكي على الكلاسيفيكيشن على central necrosis, invasion of the vessels.
إذا في calcification, there is no calcification.
Yes, but
in this
no
patient, there is
important to mention. There is no.
Yeah, in this patient, there is no calcification. There is calcification in the thymoma. Yes, but in this patient, there is no. And you see here, the mass lesion, it is lobulated, well-defined, and not infiltrating, لازم مع الوصف هذا, not infiltrating the fatty planes, and not associated with lymphadenopathy,
and no
also
vascular
not
invasion.
associated with the pleural effusion also. Negative findings, findings, it is very important. مرات لازم تذكروها بوقت الامتحان. Negative findings, it is important to mention. Okay? Okay. حكينا differential diagnosis. We have some type of thymic tumor you know. How many types of thymic tumor you know?
thymoma.
Huh?
والمالجنت also.
Invasive.
We have two types of
thymoma,
epithelial thymoma and thymic carcinoma. Okay, and these about thymoma, it represents about 15 to 20% of primary mediastinal masses, and as we said, the age between the 50 and 60. نوفل وجان شو اسمه myasthenia gravis associated with thymoma. It is about, we have a rule أو قاعدة بيسموها 40 and 15, 40% and 15%. 40% of thymoma has myasthenia gravis. 15 تقريبا 15% of 15% of myasthenia gravis have thymoma. Okay, as we said, we have two types. we have epithelial tumor and thymic carcinoma and metastasis in to the pleural cavity. What we call that metastasis? A drop metastasis. Okay. Okay, this is the location of the thymoma here. This is the location. It is anteriorly and can go to the cardiophrenic angles or spaces. إذا حضرتوا المحاضرة هذيك مرة على الكارديوفرينيك spaces, and this is the horseshoe of the location of the thymoma. This is like this location, and as we said, we have two types. Invasive and non-invasive, and with the invasive, with the non-invasive, we have a preserved fatty glands, smaller and normally pleural and usually solitary. And invasive, we have absent fatty glands, heterogeneous enhancement, and there is a pleural effusion or nodules, and spread to the lymph node. Okay, and here this patient is a small mass lesion in the anterior superior mediastinum. This is will preserve the fatty glands, no pleural thickening, pleural effusion or pleural nodules. Here, this mass, another patient with invasive carcinoma with calcification, as we see here, with effusion and with the pleural nodularity and some lymph node here. Okay.
Sometimes it's presented with red blood cell aplasia.
Yes.
Sometimes thymoma presented with red blood cell aplasia. About 5% of
Okay.
these have
This is
about 30% who have red blood aplasia have thymoma.
Okay, what you said here, Nathan, what you said.
Yes.
Okay, thymic. What we say. Wait, Nathan, wait.
Yes.
Neuroblastoma syndrome. It is associated in the thymoma about 40%. حكينا عن المايستينيا جريفيس وحكينا على red cell aplasia 5% and hypogammaglobulinemia 10%. You should have knowledge better than me in clinical, okay? In radiological not radiological finding, in المعلومات النظرية, because you are fresh, okay? مظبوط ولا لا؟
Yes.
Yeah, you are fresh. أنا old man بس أنا I will give you the tips and the tricks in the images, okay? المعلومات النظرية هاي أنت بتعلمني إياها, okay?
Yeah, true.
We cannot differentiate actually 100% between invasive and non-invasive because we are not histology. Imaging, it is not histology. But if we see lymphadenopathy, if we see a pleural effusion, metastasis, it is more with invasive type. Okay? حكينا عن calcification, it is about 1/3 of patient are presented with calcification. We have cystic changes, we have necrosis, okay? And liver metastasis, lung metastasis is more with thymic carcinoma rather than with with epithelial neoplasm, okay?
Okay.
Any question on this thymoma classic case?
No, doctor, just a question about the chest X-ray. I saw on chest X-ray reticular changes in the lung. So we need also lung window?
دقيقة شوي. You see what?
Reticular change. Both lung zone, not this chest X-ray, the previous one.
Yeah. That reticular changes.
Heaviness.
Wait.
Heaviness in both sides.
This is male. This is male. Okay. Wait. This is male. Second, a little bit softer. And if you want to check to see there's reticular changes or Not you should see what? You should see the outer 1/3 of the chest. Outer 1/3 of the chest should be free of marking. Here it is free of marking or not? اللي سأل السؤال. Here outer 1/3 it is free of marking. So these are not reticular changes. Okay?
Okay.
Any
Excuse me,
other?
doctor.
تفضل.
What about thymic hyperplasia?
Okay, مالها?
Is it as a mass?
Yeah, it is a mass lesion. Can be mass lesion. Can be after radio, مثلا chemotherapy, thymic hyperplasia. Can be looks like mass lesion. And the diagnosis of that mass lesion is شو بتسوي؟ ايش؟ Classic for the thymic hyperplasia. You know?
Follow up.
Know what you do for thymic hyperplasia? شو بتسوي للادرينال ادينوما انت؟
face or out face?
In face, out face. Okay.
Yes.
بالادرينال ادينوما بتسوي in face, out face. And the adrenal adenoma, if it is adenoma, it will be suppressed in the out face. Also, in thymic hyperplasia, we do in face, out face, and it will suppress in out face. And this is the classic for hyperplasia.
Please, doctor, may I ask a question?
تفضلي.
What about the left lower border of the heart? For the first time, I think it was left lower loop collapse. Is it normal?
No, there is no double shadow. No double shadow for that.
Okay.
And we see here there is nothing in the. This is the lower loop, مظبوط.
Okay. On the lateral, no, it's normal, but just on the frontal.
Okay, and here it is free. The spine here, it is well aerated. It is okay.
Okay.
Okay, any question on this? Okay, this is classic thymoma. Okay, our case, finished thymoma. Okay, next case. Okay, ما راح نحكي طول عمر. You should know the age. Okay. Anyone who want to volunteer? Volunteer? Anyone?
Pelvic X-ray. Pelvic
X-ray.
منا اللي شوفوا اللي بدي يحكي بالتتابع. اي واحد ما يحكي واحد لما واحد ثاني يحكي. يعني اذا واحد بدا يحكي الثاني ما يصير يحكي يلخبط عليه. اوكي؟
ممتاز دكتور.
بليز دكتور خلي طفوا الصوت.
اذا بده يحكي مين بده هون مين هم؟ سحب حاله. Anyone who want to speak?
Pelvic X-ray showing.
علي صوتك.
Pelvic X-ray showing radiolucent nidus lesion in the femur, right femur of the femur surrounding by sclerosing.
wait كمل الوصف نوفل. انت بدك تفوت الامتحان. مظبوط؟ مظبوط؟
Yes, radiolucent lesion.
Where it is located in the femur? You should mention the exact location.
Yes, in the neck, in the basis of the neck.
In the neck, okay, in the neck.
Of the femur, and the femur. In the neck of the femur.
In the neck of the femur, طيب.
Surrounding by sclerosing.
Surrounding by sclerosing. Okay, بعد.
There is no breast reaction.
There
is no breast reaction.
Okay, no breast reaction. Okay.
Yes.
Okay. Summarize again. Summarize and your differential diagnosis. Summarize your findings.
Summarize my findings. There is a lytic lesion in the neck of the right femur.
ايش حكيت لي اوكي.
Yes, is a radiolucent area.
Radiolucent area in the neck of the femur. Okay.
In the medial side of it.
On the medial side. Okay. Very good.
The surrounding by sclerosing.
Surrounding by sclerosing. Okay. Okay.
There's no periosteal reaction.
No periosteal reaction. Okay. That sclerosis is surrounding what? Why there's sclerosis? It is pathological or it is reactive?
Reaction. It's the reactionary.
Reactive.
It is reactive. Okay. It is
there is nidus of the vessels are there, and
okay.
there is reactionary, and there is
okay. What is your differential?
Osteoid osteoma.
Osteoid osteoma or بعد other differential?
Osteoblastoma, but it's more than 2 centimeters. It's more than 2 centimeters.
Nidus reducent area.
Okay. Other differential?
Sequestrum.
من وين؟
Sequestrum
there is roof changes in the acetabulum.
Eosinophilic granuloma sometimes.
Oh, eosinophilic granuloma, another differential, other differential.
Brody's abscess.
What is abscess? Okay. How to prove what you said?
By CT.
By CT. شو بتشوف بالCT scan?
There is nidus.
Nidus inside.
Nidus, radiolucent nidus, or the vessels.
Okay, this is the CT scan.
Nidus.
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 There's a nidus.
We see the nidus, radiolucent area, and calcification inside. And this, yeah, and this is the sclerosis around the nidus. And the nidus should, if it is less than 2 centimeters, to call it osteoid osteoma.
Osteoblastoma.
And this is in the coronal reconstruction. You should mention that, yeah, Nofal. And this is axial reconstruction, axial images, and you see the nidus and the calcification. Okay? And the calcification. طيب, what is the clinical patient presented with this?
Presented with severe
pain.
Pain relieved by aspirin.
Pain relieved by aspirin. Analgesic anti-inflammatory.
Pain at night.
Pain relieved by aspirin.
By aspirin.
Pain at night. Okay. Why?
But
is there anything?
Particular.
Wait. Is there anything here in this patient? You طلع على bone window of this axial cut. Is there anything here around the hip, around the neck? طلع حول قارن الرايت مع الليفت.
Soft tissue.
There is enlargement.
There is enlargement soft tissue around the neck of the femur. Here you see it. You see this is enlargement of soft tissue, and this it is a fluid. This is a fluid. Okay, a fluid reactionary fluid, joint effusion in this patient. Okay. طيب.
Okay.
What is the, if we do
in the bone scan, we can see the double density sign.
Bone
scan.
Okay, very good.
Double density sign.
Other advantage of bone scan, other than the diagnosis?
To see if there is more than one nidus before treatment.
Okay, we can apply the bone scan with Geiger scan in the operating room, and you see it is any left of the nidus there or not. Okay, but nowadays the treatment is Nowadays, the treatment is
radio frequency
radio
ablation.
frequency
Ablation.
ablation. Radio
Ablation
frequency
is intervention.
ablation. Nowadays, the treatment it is radio frequency
guided.
ablation. Either okay, CT guided, okay. أو شو اسمه. Okay. So this is some information about the osteoid osteoma. It is benign tumor contained osteoid stroma and less than 2 centimeters in size. Common site, it is femur, tibia, humerus, most common areas. And if it is in the spine, تعطينا scoliosis, painful scoliosis, and sometimes we have three types, by the way, of osteoid osteoma. You can check the book again at where's the location of the osteoid osteoma. Here in this patient, it is cortical, but can be in the periosteum and give osteal reaction. There is 3 types of osteoid osteoma around the location. Okay, check the book for that. And increase uptake, as you said, and CT scan, small lucent area contain calcification surrounded by reactive sclerosis, and MRI radiolucent area, NIDAS, it is hyper intense in T2 with sclerosis in the hypo-intense. Any question on the osteoid osteoma? I think we cover everything in the osteoid osteoma, I think, huh?
Yes.
Okay. نشوف this is short case and this is the last case, okay? This patient presented with sensory neural hearing loss. Okay, and what do you see?
Acoustic neuroma.
Acoustic schwano.
حكينا منا الفايف notes, 5 points to fill the 5 points. مناش spot diagnosis. And your spot diagnosis is wrong also. It is not. Okay? منا وصف. We need what is the procedure? What is your finding? And we need the differential diagnosis, and we need also our most likely diagnosis and our recommendation. Okay?
Okay.
What is the procedure here?
أحكي.
تفضل.
Serial images of axial brain MRI, T1 and T1 with contrast, third image.
Okay, very good. Okay.
And fourth image, I think it is flare image.
T2, T1, okay, اللي حكيتيهم. Okay, ما في.
Showing their high signal intensity in both T1 and T2 at the right CP angle.
It is CP angle here. طلع عليها مظبوط.
CP angle.
CP angle.
It is CP angle?
No.
It is not CP angle.
It is above CP angle.
It is above CP angle.
It is the right petrous apex.
Very good. Right petrous apex. Okay.
So I have multiple MRI section, T1, T2.
Okay.
At the level of the petrous apex bone, the lesion showing hyper signal intensity on T1, hyper signal intensity on T2.
Very good. And in contrast?
In contrast, so it is hyper in T1.
Okay, well, no definite enhancement. Okay,
not enhancing.
No enhancing. Okay, what is your differential?
Cholesterol granuloma. Because it's hyper on T1.
This is one of the
And the
differential.
second differential is congenital cholesteatoma.
Congenital cholesteatoma, very good. Okay.
Then so I need diffusion.
Okay, ما عندنا diffusion. Okay, ما عندنا diffusion. Okay, ماشي. Other, you know other differential?
Epidermoid cyst.
dermoid not epidermoid.
Epidermoid
هتبقى مش high signal.
Rupture dermoid cyst.
Okay.
Sir, the epidermoid is the same as congenital cholesteatoma.
Okay.
The same.
No.
Okay. Okay, the main differential here, it is cholesterol granuloma and cholesteatoma, okay? Epidermoid cyst, it is in the CSF spaces, okay? Not in the apitus apex, okay?
Some books called the congenital cholesteatoma as epidermoid.
Yeah, I know that, yeah. I know that, but other differential, if it is, this is 50 years old, okay? Could be metastasis.
Metastasis? I know that the metastasis is mostly hypo in T1 upper in T2.
Okay, إذا كانت hyper in T1, T2.
You mean melanoma metastasis?
Melanoma, okay, but okay, but with it is in melanoma, it is enhancing tumor, okay?
Yes.
And
mostly it is hypo in T2.
And could be chordoma?
No, not midline.
Chordoma is hypo in T1.
Hypo in T1 could be another differential, but it is not fit with our MRI finding. Okay.
But the lesion appear benign in appearance. It is well defined, not aggressively behavior.
Not aggressive. It is well defined, not enhancing, and it is cholesterol
granuloma. To confirm my diagnosis, I need a fusion image.
Okay. شو بتشوفي؟
To differentiate it from the cholesteatoma, because congenital cholesteatoma is restricted on diffusion.
Okay, very good. Okay, these are our differential, and this is the classic case of cholesterol granuloma. Okay. Okay. Any question on this cholesterol granuloma and its differential?
Sorry, sir. One of the differential diagnoses is the osteitis of the apex of the petrous
it is
bone.
osteitis, yeah, but with that you have, it is not well defined, huh? مظبوط?
Exactly, yeah. And it, I think it is hypointense in T1.
Yes. Okay, other differential, they put in the book hydrated mucocele. I don't know what is hydrated mucocele. It is, they said it is rare. Okay.
Other differential diagnosis put on the not on the imaging feature, but put them on the anatomical side.
Yeah, in the location, aneurysm.
And the location.
Yeah, aneurysm.
Trapped fluid or infection.
Okay.
I think petrous encephalocele.
Okay.
Excuse me, doctor.
تفضل.
What about endolymphatic sac tumor?
Endolymphatic على الفستيبيول تحت, not here. مظبوط.
Thank you.
Doctor, we can't put
in the vestibule, not okay.
Doctor, we can't put hemorrhagic cystic adenoma.
Hemorrhagic cystic adenoma. This cholesterol granuloma can bleed, but it is microbleed. Can bleed, but it is microbleed. And during examination with the ENT man, he can see hemorrhage in the tympanic cavity. Okay?
Okay.
It is a cyst, by the way. This is a cyst, but microbleed in this cyst. Okay?
Okay.
Any question? Okay, we can stop here inshallah.
Doctor, can put mucocele of the petrous.
حكينا other differential diagnosis بيكون اللي هو hydrated mucocele. Hydrated mucocele, it is one of the differential diagnoses, and it is بيكون على T1 و T2 the same high. Okay, but we also no enhancement. This is hydrated mucosa. Okay.
اوكي شكرا دكتور.
اوكي
شكرا استاذ شكرا.
بجوز احتمال كبير يوم الاربعاء we have short talk. اوكي short talk بنعلن عنها
استاذ هشام ممكن سؤال؟ الله يعافيك الله يسلمك. ممكن سؤال؟
تفضل يا سيدي.
دكتور معلش بس بالنسبه للكيس السابقه البون مارو اديما بالفيرتبرا البديل اللي على طرفي الديسك سبيس اما ديجنريشن او ديسكايتس او اكيوت شمورال نتيور اللي بتعمل ريستريكشن فقط هي الانفكشن. يعني
بس الانفكشن انفكشن بتعمل
ريستريكشن
وخاصه ابسس مش بس
الابسس في اي مكان بالجسم بريستريكشن.
بس انت it is the restriction due to abscess مش من restriction due to infection by the way.
يعني اذا ما في ابسس مثلا لسه الديسكايتس ما عمل بيري
ما عمل كونكشن ما اظن يعطيك ريستريكشن ما اتوقع.
ايوه اذا الريستريكشن هو نابعه من البيري فيرتبرال بس كولكشن يعني من الابسس.
it is abscess it is collection but here the case أنا فرديتك.
طيب شكرا جزيلا دكتور.
أنا فرديتك هون in this patient probably this is small node لأنه في عندنا multiple limbus vertebra not united. Okay and this is can small node by the way can presented with acute pain. Acute small node. There is a syndrome. There is a syndrome called acute small node syndrome.
صحيح. صحيح.
طبعا اقرا عنه. اقرا عنه اكثر من عندي لانك بيجوز تقرا اكثر من عندي. اوكي بس these are the one of the differential. Okay but at least the patient has no signs of infection. يعني حتى بالماركرز في reactive protein there is no infection etc. اوكي اذا نشوفكم ان شاء الله يوم الاربعاء مع short talk about 15 to 20 minutes. I don't know what is the subject بدي انقي لكم اياه اليوم ونحكي قبل بيوم ان شاء الله.
دكتور ممكن يكون ساعة بالعشرة؟
الساعة بالعشرة نحطه على الساعة بالعشرة بنحطه على الساعة بالعشرة ما عندنا مشكلة. اوكي ما عندنا مشكلة بنحطه على الساعة بالعشرة.
شكرا استاذ. شكرا جزيلا.
شكرا جزيلا.
بارك الله فيك.
شكرا جزيلا
ان شاء الله. اوكي يلا نشوفكم.
شكرا جزيلا دكتور.
شكرا يا سيدي.
شكرا دكتور يعطيك العافية.
شكرا جزيلا مع السلامة. نشوفكم على خير ان شاء الله وتصبحوا على خير ان شاء الله.